Thank you, moderators. Good morning, everybody. Thanks also for the opportunity to present our work today. First of all, my disclosure. I want to say that I have nothing to disclose. The context of our study is the gut microbiota. We all know that gut microbiota is a highly dynamic system, and there are several factors that are able to shape, to modify this fine ecosystem, as diet, the environment, the lifestyle, the antibiotic treatment, as well as different pharmacological treatments, as well as stress. In the adult, the microbiota is dominated by taxa belonging principally to big families of bacteria, the Bacteroides and the Firmicutes phyla. And in obesity, there was reported firstly an imbalance between these two big families, with an increase in Firmicutes and a decrease in Bacteroidetes. But it's not so simple, the pattern of gut microbiota in obesity, because also we have recent data concerning also an important decrease in richness in biodiversity of several families of bacteria. More than that, we have also to take in account of the effect of aging in the shape of this fine ecosystem, because the aging is a physiological process, but there are studies showing that during aging we have a physiological decrease in the amount of the bacteria, and the healthy aging as well as the longevity were associated to a preservation of the richness of the diversity of these bacterial strains. So, since obesity is a chronic relapsing disease, we now probably face more and more to obese patients in advanced ages. So we decided to study and to compare the intestinal microbiota in elderly obese subjects with that of elderly non-obese, lean, healthy subjects, to study the microbiota modification in elderly obese after a short-term balanced hypocaloric diet to induce weight loss, and also to assess the effect of a probiotic supplementation mixture commercially available on, together with the diet, of course, in a gut microbiota composition, and to check also at the variation in the clinical parameter at a systemic level. This is the flow chart of our study. We enrolled 26 obese patients, and of course we excluded all the situations that could make a bias in the data interpretation, as bariatric surgery procedures, inflammatory bowel diseases or cancers, and also the therapy with antibiotics, probiotic, vitamins, PPI, and as well as metformin in the case of diabetic patients. So the fecal samples, to avoid additional bias, we asked to the patient to collect at home the basal fecal samples that we consider at the T0, and we compared these fecal samples with the samples from 15 elderly non-obese controls. And then at the hospital, so during the hospitalization, we submitted our patient to 15 days of diet, and the following 15 days, the diet plus a probiotic supplementation. All the fecal samples collected were analyzed by sequencing. Here I'm showing the characteristic of our population studied. So the mean age was 79 years. We had a high level of obesity, and you can see an excess of fat mass. And at clinical level, the major complications were orthopedics and cardiovascular. We had also patients with OSA, and more than half of the sample declared chronic constipation. We tried to characterize the morphology of the fecal sample by the Bristol stool chart, and all the samples were in between type 3 and type 4 morphology. That was in agreement with the assessment of calprotectin, fecal calprotectin, that it is a protein and marker of an inflammatory state of the gut, of the intestine. Then some information about concerning the diet we performed during the hospitalization. It was a balanced diet. Here you can see the composition in micronutrients, in carbohydrates, lipids, and proteins, and this followed the recommendation of the Italian Society for Human Nutrition, recently revised. And this is the supplement we used. It's a commercially available mixture of probiotics, and we decided to use this product because of the richness in bacteria, 450 billion of bacteria, and also for the different strain. We have several strains of Lactobacillus and Bifidobacteria, as well as Streptococcus thermophilus, that is in different mixture of supplementation. Here I'm showing the changes in food consumption before and during hospitalization of our patients. Of course, at the hospital, we increased the assumption of vegetables and also of whole grains and cereals instead of white bread or pasta. We regulated the amount of fruit, of daily fruits, and increased as protein level the legumes consumption and also the eggs, reducing cheese and meat. Of course, at the hospital, wine was not allowed. And the average daily water intake was followed the recommendation. This is the baseline comparison in elderly obese, non-obese control. It is immediate to see that two groups are well separated, and in red you see the obese, and in green the elderly non-obese control. And we also have observed that the obese patient had a lower biodiversity, that this biodiversity decreases at the increase in body mass index. This is the detail of this previous comparison between obese and non-obese control elderly. And as you can see, we had an increase in Streptococcaceae, Collinsella, Peptostreptococcaceae. The Lactobacillus was not really significantly different, and there was a significant decrease in Blausia, Coprococcus, Roseburia, and Parabacteroidetes that are all healthy associated bacteria. So this picture shows that also in elderly obese we have typical alterations obesity linked. This is the effect of our intervention after the 2 weeks of diet and 2 weeks of diet plus the probiotic, and we had a good decrease in calprotectin, in fecal calprotectin, and the weight loss was globally the 2.5% of the initial weight. That it's a satisfactory weight loss if considering that we are working with elderly obese patients, so the risk of loss of free fat mass, it is very, very high. And the effect of the intervention of microbiome diversity is shown here. And as you can see, at this stage we cannot distinguish the 3 points, the basal samples after 2 weeks of diet and 2 weeks of diet and probiotic supplementation. But there is a shift of yellow point and orange point on the left of this scheme. That means that we have increased the richness, the diversity of intestinal bacteria in this sample. And the more patients that shifted on the left were after the 2 weeks of diet. This is the detail of this analysis. We increased the Bacteroidaceae and Corybacteroidaceae. There was a significant decrease in Enterobacteriaceae, Enterococcaceae, and the Verrucum microbiaceae increased, and Akkermansia mucilifila belongs to this group of bacteria. And as expected, the Lactobacillus increased only with the supplementation. That was also an expected result. At clinical level, we had globally an improvement in all the metabolism, glucidic and lipidic metabolism in these patients. And I don't have the time to show all the details, but we had an interesting, significant increase in the redox potential in this patient with the increased amount of glutathione reduced and the glutathione reduced oxidated ratio. So we improved mainly with the supplementation the potential redox. The correlation part of the study with all the clinical features we have and also with diet, the frequency is still in progress, but I want to show the principal correlation we found and stressing the point that is the body mass index, the big driver of gut dysbiosis, as you can see here with an increase in Enterobacteriaceae and a decrease of Microbiaceae. Interestingly, also the ratio of redox potential of glutathione was related to the decrease of unhealthy bacteria, and as well as the increase in adiponectin and leptin levels were significantly related to movement of these healthy, unhealthy bacteria. So, in conclusion, the gut microbiome in elderly obese subjects show typical features of dysbiosis as for all the obese people. The lower diversity in the obese compared to the non-obese is maintained also in advanced age. And in elderly obese subjects, a recovery of health-promoting gut microbial configuration could be rapidly obtained by a short-term balanced hypocaloric diet that I want to call Mediterranean-like, but we have to better define what this type of diet is. And the probiotic supplementation induces a decrease in the oxidative stress that is important to face off several mechanisms of oxidation at cellular level. And of course, for the future, a longer follow-up is needed to verify the stability of this improvement because, of course, we checked the patient for 1 month and to see if this improvement could be obtained in longer follow-up. First, at the end, let me thank all the people involved in this study, in particular all the clinicians and biologists of the San Giuseppe Hospital in Piancavallo of the Istituto Oxologico Italiano, and all the team of Patrizia Brigidi at the University of Bologna for the support in microbe characterization. Thank you very much for your attention.
Thank you very much for this interesting presentation. Are there any questions? Maybe I ask you one. Do you have follow-up data on these patients? What happened after this?
Yes, unfortunately not. But we want to check also this patient at the follow-up because we plan usually a checkup every 3 months after the recovery at the hospital, after the hospitalization. So we have to do that. I agree.
What do you think would be when you continue with the probiotic treatment, and regardless of diet? What about the composition of bacteria?
This particular probiotic mixture is probably the probiotic mixture with a big amount of literature and scientific studies. The probiotic itself does not improve weight loss without a diet. This is well known. But I think it's a powerful tool for to re-equilibrate other patterns, other metabolisms.
Thank you.